Can the speaker, yeah, stream is live. Okay.
Yes. So, good evening, everyone, and welcome to the Expert webinar. I take this opportunity to welcome you on the behalf of Juventus and the Juventus head office team, which is headed by our VP Sales and Marketing, Mr. Vishnu Kasara, Mrs. Javeria Momin, DGM Marketing, and our state head of Maharashtra, Mr. Ullas. My colleague, Ms. Prachi, is here, and myself, Harshada Kaur. It is known that exocrine pancreatic insufficiency and diabetes may coexist, and despite its high prevalence, little is known about the clinical consequences and its optimal treatment. So, I am very excited to introduce our eminent speaker, Dr. Gandhi. His talk will address the challenges in management of coexisting EPI and diabetes. Dr. Sanjay Gandhi is a senior diabetologist in Pune. He is a panel diabetologist with hospitals like Pune Hospital, Sanjeevan Hospitals in Pune, and he is having his private diabetes care setup also. So, request to all the viewers for any query, kindly type content in the chat box, and Dr. Gandhi will answer the same. So, I request Dr. Gandhi to let us through the very less known topic, that is exocrine pancreatic insufficiency and diabetes coexistence. Over
All
to you,
right.
sir.
Right. Thank you very much. Thank you. I really appreciate. And good evening to all the listeners as well as my Juventus friends and the smart yard. I am actually quite used to this Zoom as well as the what do other say, the Teams. But this is a new platform, and it's a very wonderful thing. I am learning it, and I think even though I would be touching almost the completing the sixth decade of my life, still I am learning and I'm happy to learn. And I thank Mr. Kulkarni of Juventus to give me this opportunity to communicate to you all about this very interesting, kind of, I would not say neglected, but kind of overlooked or not attended topic, either from the person who is suffering from diabetes, or I would say PWD, the person with diabetes, as well as the person who treats him, that is healthcare professional. So what's happening? Hello?
Sir.
Hello? Yeah?
Yes, sir, we can hear you,
I'm
sir.
not I'm not able to see the slides.
Yes, slides are there, sir. Now, are you able to see that?
Yes?
Huh. Yes, sir.
And you will be kind of changing the slides, isn't it?
Sure, sir. Sure, sir. Yes.
That's fine. That's fine. So good. Well, this is a very interesting topic, either for the person who has diabetes, as well as for the relatives of that person who with diabetes, as well as for the healthcare professionals who are
बोला
treating a
फटाफट बोला पुढे
person
बोला मला काम
with diabetes. कुलकर्णी सर, तुम्ही मध्ये बोलताय, तुम्हाला म्यूट केलं तर चालेल. So that's, thank you very much. And so let me talk to about this particular topic, which is, I would not say overlooked, but quite often kind of uh, gets just waved off, because person keeps on telling about I have a pain in stomach, or I पेट में दर्द है, gases होते हैं, टॉयलेट को कभी कभी लूज मोशन हो जाते हैं. The person with diabetes keeps on telling me like this. But then do I need to kind of give attention to his complaints like this, whether it is related to my medication given to the person, or whether it is related to something else, some different pathophysiology into the person's body? Am I treating only a person with high sugar, that is hyperglycemia, or something else? So that's how this topic came to, our discussion between me and Mr. Ullas Kulkarni. He is actually a very wonderful person. I know him since last 2 decades now. And so this topic of exocrine pancreatic insufficiency with diabetes is an important topic. Quite often we keep on seeing a patient with diabetes. We talk to the person with diabetes about insulin, about the pathophysiology, the pancreas producing the insulin from beta cells, of from the isolates of Langerhans bus. The diabetes pathophysiology stops there, and then the complications of diabetes topic starts, and we keep on telling the person that you should not develop the retinopathy, the nephropathy, the neuropathy, the heart disease is more common with diabetes, the central nervous system problems like stroke or लकवा जिसे हम कहते हैं, that is very common with the diabetic person than the person without diabetes. But quite often I myself kind of submit or admit here that I also forget to ask him about any indigestion, any abdominal trouble, any trouble like, okay, somebody says, no, I get anorexia, I get burning, I get burning in the chest, burning in the stomach, bloating in the stomach. So I connect it with something which is so commonly used in diabetes, that is metformin, the first drug to be used in addition to the lifestyle modification, like advising about nutritional therapy or diet control, advising about the exercise schedule for the person. And after that, metformin has been the first drug. Things are changing. Last 5 days or 5 years, or I would say 2-3 years, the things are changing. Quite often we do treat patients with something else than metformin in diabetes practice nowadays. But still, even after having done such a big change in the horizon of the medications available for diabetes, I probably admit here that I also miss the question to be asked to the person with diabetes about exocrine or digestion trouble with him associated with his hyperglycemia or high blood sugars. So therefore, this topic is very important. May I get the next slide, please? Now, I want to tell you what is the prevalence of diabetes. Now, this is the outline of today's presentation. Let me give you the things like, no, wait, go back. I would love to have the control myself, but anyway, so this is the outline of today's presentation. Epidemiology, what is the connection between the insulin or diabetes as such, or the hyperglycemia and the pancreatic insufficiency, or जिसे हम simple भाषा में कहेंगे अपचन. We keep on seeing that ad on the television about what पेट सफा हरदम वफा, this, that, all those indigestion things, constipation, loose motions, all those symptoms are associated with the person with diabetes, but it doesn't click to my brain that can he have something which is insufficient from pancreas, something which is some enzymes insufficiently coming from pancreatic secretions coming into the intestine for digestion of his own food. So that is there. That connection we have to explore. So therefore, we are going into the next is pathophysiology of these two things, the connection between the hyperglycemia and the exocrine pancreatic insufficiency. Diagnosis, how do I diagnose this exocrine pancreatic insufficiency? Is there any classification? Is there related to the cause of pancreatic disease as such? That we'll go to that topic. How do I manage it? Does pancreatic enzyme supplementation helps to these patients? What are the supplementations available? What is the dose I start with? How do I go about it? And then we would conclude with the questions coming from the audience if it is possible. Next slide. So now the epidemiology, about epidemiology of diabetes as such, we know about 7 to 7.5% of people are having diabetes as such diagnosed in India. But let me also tell you an important thing. Almost equal number of persons with diabetes are still remaining undiagnosed in this our poor country with largest population of the world, and obviously associated with largest population with type 2 diabetes mellitus patients all over the world. Now we are going to see what is the prevalence of this exocrine pancreatic insufficiency or indigestion as such with type 1 diabetes, almost 74%. You can see 3/4 of people with diabetes. As such, type 1 diabetes is very small sector of total number of diabetes patients, maybe about 2% or less than that. But rest of the 95% of type 2 diabetes mellitus patients also have half of them. 54% of those type 2 diabetes mellitus patients, which is common type of diabetes, diabetes associated with obesity, diabetes associated with the word called diabetes. If we utter a word diabetes, the common thing coming to our mind is type 2 diabetes mellitus, and almost half of their patients are having this exocrine pancreatic insufficiency. Again, I want to say undiagnosed or untapped or not discussed by the healthcare professional to the victim, or I would say person with diabetes, the person who suffers with hyperglycemia as well as the indigestion trouble indicated by exocrine pancreatic insufficiency. Next slide. Next slide, please. I don't know why your name has come as Enzelo. This seems very fantastic name, though it looks like a Christian name, but it is Gonsalves like Enzelo. But let me tell you all my friends that a pancreatic enzyme supplementation comes from this company called Xpert by the name Enzelo. So that's a very wonderful name and very easy to remember because it is enzyme supplying Enzelo, which treats the exocrine pancreatic insufficiency. This is actually the last part of my presentation, but I have already uttered because of not knowing your name. Somebody is there, Prachi Bendare. Hi, madam. Thank you for being there. So now let's go to the hidden diabetic pandemic. What is there in the world happening? 8% is the global prevalence of diabetes. We know now 7.5 to 8. 10% of all new diabetes cases diagnosed could have DEP. What is it? That diabetes of exocrine pancreatic origin. So approximately 40% of all patients with diabetes show alteration in exocrine pancreatic morphology. Morphology is the structure of the pancreas. That also shows the alteration almost 40% of patients with diabetes. So DEP is undiagnosed, underdiagnosed, usually mistaken for type 2 diabetes mellitus, which is T2DM, we call it as a nomer. So there is a funny thing happening here. Diabetes of pancreatic origin and type 2 diabetes mellitus are two separate things, is what actually this slide is trying to teach us or give us the information about. Next slide. So this connection we are going to find out now. The connection is what? Insulin is secreted by beta cells from the islets of Langerhans. Islets of Langerhans do not have a wall. Like a fort or a city is, having a wall around it and there is a gate to that city. So similarly, islets of Langerhans is a kind of collection of bunch of cells, but it does not have wall. So that means the pancreatic cells or acini which secrete the enzyme and the cells, beta cells which secrete insulin or alpha cells which secrete glucagon, they are from the islets of Langerhans inside the pancreas itself, do not have a kind of separation or a wall in between. This is just an information to keep with. Next slide. So this diabetes affects the exocrine pancreas, meaning somebody who has got diabetes, how does it affect the enzyme secretion from pancreas? There are quite a few things to, kind of take into consideration how diabetes will affect the exocrine pancreatic. First is that could be a genetic tendency for pancreatic damage. That's one. Like even diabetes, type 2 diabetes mellitus also has a genetic markers in some chromosome 11, chromosome 7 or kind of thing. Similarly, pancreatic damage in exocrine way also has some genetic tendency. In addition to that, autoimmune mediated inflammation happening in pancreas, meaning we know now the autoimmune diseases like rheumatoid arthritis, psoriasis, or the white plaques or leukoderma, which we might call, are autoimmune kind of diseases where our own cell, body T lymphocytes do not identify our own cells as our own and fight against those cells like joint cells. So that's happening in rheumatoid arthritis. Similar thing might be happening in the exocrine pancreatic domain. Similarly, some vascular damage in the local part in the exocrine as well as general vascular damage in the sense where the vasculitis is there happening or atherosclerotic disease is there or scleroderma is there. So such kind of vascular disease in general or vascular disease in local pancreatic artery happening, and that affects the exocrine pancreatic function. Similarly, the atrophy of exocrine tissue due to lack of local trophic hormone, that is insulin. Now, insulin coming out from beta cells of islets of Langerhans also goes through the similar artery to the next acini, which secrete enzyme, which is a part of exocrine pancreatic part, that acts as a trophic hormone. Trophic meaning a growth hormone or an anabolic hormone, or does not allow the cell to die. Otherwise, the cell is going to die. Apoptosis happening in the each cell, meaning each cell has its own life. The small cell, then it enlarges, then it goes into a proper cell, then it starts getting degenerated, and then it starts apoptosis. That is a cell cycle. But here, insulin from islets of Langerhans, insulin from beta cells of islets of Langerhans work as a trophic hormone with those enzyme secreting pancreatic cells from the acini, which is just next door the islets of Langerhans. So all these factors affect, and ultimately what happens? Dysregulation of exocrine secretion due to diabetic neuropathy additionally. Diabetic autonomic neuropathy is one additional thing in addition to your common nerves problem. What is that diabetic neuropathy? Our fingers, our the legs or the toes also suffer from this neuropathy. But there is a third neuropathy which is called, one is sensory neuropathy, one is motor neuropathy, and third one is called autonomic neuropathy, which is transmitted through the parasympathetic nervous system, through vagus nerve from the medulla down to the abdomen, and as well as to the pancreatic acini and pancreatic exocrine part. So that is also affected by diabetic status or hyperglycemia, and that makes the dysregulation of the exocrine secretion from the exocrine pancreas as such. So now this is how sugar or various other factors affect the exocrine pancreatic function. Next slide. Now here, this slide particularly indicates various pancreatic disorders which are related, like chronic pancreatitis is one important disease in the gastroenterology part of it, which as well as pancreas also gets affected in a disease called hemochromatosis. Pancreas also gets affected with development of pancreatic cancers, as well as cystic fibrosis, one disease which affects the various glands, the cystic glands in the body, and pancreas is one of the cystic gland because it has acini, it has cyst, all those things, and that cystic fibrosis affects the exocrine pancreatic tissue as well. Now let's see what is the percentage of incidence. Very common, what we see in India. Let the slide be there, please. Yeah. Very common what we see in India is very chronic pancreatitis, whether it is related to alcohol, whether it is not related to alcohol, meaning somebody who does not drink alcohol at all still can get chronic pancreatitis or the pancreatic inflammation. Now this quite often I have seen myself happening with heavy fat meal, meaning somebody who, let me give you an example of, I'm just trying to make you understand about it. I had a patient, young man of about 38, and his son was a 4-year-old, and his birthday was there. And that evening, a good birthday party was arranged at the terrace of the same building where he was staying. So he was very happy. The cake cutting happened, all that thing happened, and that young boy of 38, a young man of 38, actually enjoyed the whole party, the photographs and all things. Then everybody had their own dinner, and this man also had dinner. But what was there in dinner? Puri, that fried puri rehta hai, गेहूं का बना हुआ fried puri. With that, Shrikhand was there. Shrikhand is a very delicacy for Maharashtrians. So Shrikhand was there. There were bhajis, the pakodas. There were as well as 2 sabjis, and there was after that ice cream. Simple vanilla ice cream, but ice cream. And after that, the cake which was cut by the boy 4-year-old boy was kept next to the ice cream. So now you imagine puri, which was fried in the oil, 2 shrikhanda, 3rd bhaji pakodas, 4th ice cream, and 5th the cake with icing or thick ice cream on it, icing on it. So now imagine all those things were taken up by that father of that 4-year-old boy. And after that, 2 a.m., same night, he started acute pain in abdomen. उसके पेट में दर्द होने लगा. And he was rushed to the hospital. About 3 a.m., he was into the hospital with tremendous pain. And that was because of the heavy fat load of that dinner, that particular. And let me also tell you further few things. His lipase and amylase, by which we test the pancreatic dysfunction, were way high, 700, 3000, all those things. And he obviously had thing called pancreatitis. Why I am telling you all this here is heavy fat meal is one of the important cause of chronic pancreatitis. And when you don't know whether your pancreas can digest all good things or not, you still eat all those 5 things together: the puris, the shrikhanda, the pakoda, the ice cream, and the cake. Calculate all those things. I am very clear on my menu because I remember that case very well. And unfortunately, I lost that young man of 38 at 7 a.m. next day morning. Why it strikes to me whenever such kind of description comes, chronic pancreatitis. So alcohol is a very important cause of chronic pancreatitis. But in addition to that, there are few things which also cause chronic pancreatitis. And one of the important fact, and we are in now different era. There are hardly things which are cooked at home. There are Zomatos, there are Swiggies, there are whatnot, all delivery things happening. Delivery meaning not pregnancy. Nowadays, young population does not want pregnancy. Quite often, I see young couple, they do not want next generation to be born to them because the lady is, worried about the pain. Now, I'm diverting a bit topic, but what I mean is, we do not know what that cooking is happening when the object comes at home, delivered by Zomato or Swiggy or anything. What is the fat content of that particular material, whether it is anything for that matter, anything. So remember, high fat containing meal does cause pancreatitis, and repeated attacks of pancreatitis, that was an acute pancreatitis, makes you to a chronic pancreatitis. So these are the causes of pancreatic disorders happening, and that affect the exocrine part of pancreas, and diabetes coexisting gives further trouble to the exocrine pancreatic tissue. Next, sir. Now we will go to the structure of pancreas, where it is placed. So this is duodenum, the second part of duodenum, or after the stomach, the small intestine starts. So this is the duodenum. This is the third part of duodenum, and up here is the fourth part of duodenum. This is the thing called pancreas, and this is the pancreatic duct here. And you can see a small cells which are acini, and this is the exocrine pancreatic tissue. So exocrine pancreas protease affect the function of endocrine pancreas. Understand me that these acini are there from the exocrine, and next to it are the islets of Langerhans or the endocrine pancreatic tissue. So sometimes the leakage of pancreatic proteases also affect the islets of Langerhans, that is the endocrine part of pancreas. Now, overexpression of pancreatic proteases also increases the number of beta cell. There is an integrated blood flow between the exocrine and endocrine pancreas, meaning what? Same blood vessel, which is pancreatic artery, supplies the islets of Langerhans as well as the exocrine pancreatic tissue or the acini. Now, the insulin secreted by beta cell is directly put into the blood, and that also gets chance coming to the exocrine pancreatic tissue, which actually has a protective or trophic effect on the exocrine pancreatic. When insulin is insufficient, this trophic effect is reduced. So there is an interplay between the exocrine and endocrine pancreas. This is what we wanted to kind of understand out of this slide. Next slide, please. Next slide, please. I know I'm going a bit slow, but I shall increase my speed. So there are exocrine acini cells which actually keep cross-talking to the beta cell from islets of Langerhans. There are genetic mutations which lead to pancreatic dysfunction. We have seen that the protein response, also fat response. I want to put it here. This reference comes from our 2022, just last year, the publication. And increase in ER stress is endothelial reticulum stress, promoting the gene expression of BIP and spliced XBP1 gene. And that's how beta cell dysfunction is additionally happening. So you can see the arrows and the thing, how it progresses to the dysfunction of beta cells and ultimately leading to insulin deficiency. So there is an interplay between the exocrine pancreatic tissue to the islets of Langerhans, reducing the insulin secretion from beta cell, as well as I told you, if the insulin reduces, the trophic effect of insulin onto the exocrine acini reduces. So that's how exocrine function also reduces. This is what I wanted to kind of make you understand, that it's not only insulin insufficiency, it's not only insulin resistance, but it is also exocrine insufficiency happening in many patients of diabetes. Next slide. Here now there are marked changes happening in pancreas. So this is the comparison of people with type 2 diabetes mellitus and people without type 2 diabetes mellitus, that is non-diabetic pancreas. So what is happening here? The fibrosis in the exocrine pancreas is much more in the patients with type 2 diabetes mellitus, as well as the exocrine pancreas contain more amount of fat, either inter or intralobular inside the exocrine pancreas, as well as the T cell percentage increases. That indicates inflammation. And the small vessel angiopathy, the blood vessels are reducing in size. There is a ischemic zone happening in the exocrine pancreas, and higher prevalence of pancreatic intraepithelial neoplasm. Neoplasm is metaplasia leading to ultimately sometimes cancerous growth in the pancreatic endocrine part. So this is the difference between how do we identify a pancreas of person without diabetes and person with diabetes. So there are a few things which we need to remember. Fibrosis is excess, fat tissue is excess, the neoplasia is excess, angiopathies are there, that means vascular damage is happening, so blood flow is lesser, and the T cell percentage is more, indicating the inflammation in the exocrine pancreas. Next slide. Next slide, please. Yeah. So these are structural and functional relationships we are trying to see here. The insulo-acinar axis, I think I have already explained. The outflow from the blood from the islets of Langerhans, which takes the insulin to the acinar capillary network, and therefore the exocrine pancreas receives some part of blood flow coming from the islets nearby. You can see the blue, the picture is clear to you. The blue part which is shown here, these are the islets of Langerhans, and the beta cells are releasing the insulin, and that is directly released in the blood, and the same blood also reaches those acini which are seen like a I would not say flower, but the leaf of a plant, and those yellow things are acini, which is exocrine pancreatic tissue, and blue thing is the islets of Langerhans. As well as exocrine pancreas or the parenchyma and endocrine islets lie in the intimate contact, because as I told you in the beginning also, there is no capsule or there is no wall, there is no separating thing between the islets of Langerhans and the acini of exocrine pancreatic enzyme producing cells. Next slide. Next slide, please. Yeah. So insufficiency feed each other, meaning when there is diabetes, the insulin is insufficient. When there is exocrine disorder, that means the enzymes are lesser. So now let's see what happens. In diabetes, the insulin is a trophic hormone, we know, but that factor is reducing, which surrounds the exocrine tissue. There is an increase in exocrine secretion in response to insulin, but the insulin is insufficient, then exocrine secretion will reduce. Similarly, the autoimmune distraction between the exocrine and endocrine cell is observed especially in type 1 diabetic patient, not in type 2. The clinical correlation between exocrine and pancreatic failure is happening or seen in type 1 and type 2, that also exists. So exocrine pancreatic insufficiency and the vascular disease suggests pancreatic dysfunction in the type 2 diabetes mellitus. Autonomic neuropathy also plays a very important role in producing the exocrine pancreatic insufficiency through vagus nerve. Vagus nerve is a part of parasympathetic nervous system, which is a part of autonomic nervous system, and the autonomic neuropathy happening in diabetes leads ultimately to the additional exocrine pancreatic insufficiency. Here, chronic pancreatitis increases the pancreatic pressure. The pancreatic collagen increases, so fibrotic changes is happening in the exocrine pancreas. So you can see pancreas which is contracted at a later stage of chronic pancreatitis. Next slide. So this is the pathophysiology. Let's see what further is shown in the next slide. Yeah, I think it's a bit kind of deeper, but I would take you very fast. Alcohol consumption, gallstone, metabolic risk factor, environmental risk, genetic risk factor. We have seen this ultimately leads to acute and chronic pancreatic disease. Sometimes, for some reason, we need to do a surgical removal of pancreas, especially in the cancer patient, especially in the patients with cystic fibrosis, patients with hemochromatosis. So ultimately, all cell type actually in the islets of Langerhans are affected. Those who are secreting insulins, which is beta cells, and therefore leading to hyperglycemia and impaired. Additionally, incretin, GIP and GLP is a very important part of treatment track now in the type 2 diabetes mellitus now. Incretin effect. The incretin effect we know. So the L cells, even the release of incretin also reduces in those patients who also have the exocrine pancreatic insufficiency in addition to the diabetes. We know this, that in diabetes also the incretin effect is poor, or the GLP-1 secretion is poor or weaker. It is actually a very short time or few second acting hormone, and if it is insufficient, the insulin secretion from the beta cell reduces. So we actually provide the GLP from outside exogenously in the injection form in many patients, except that we also have tablets now of Rybelsus of semaglutide. Next slide. So in diabetes, the exocrine pancreatic insufficiency contributes to hyperglycemia, and how it makes the hyperglycemia we have seen already. The pancreatic stellate cell is what is the long form of PSC activation. Ultimately, exocrine disorder, chronic pancreatitis, increased pancreatic pressure, increased pancreatic stellate cell activation, and ultimately leading to increased glucose level because of affection of the islets of Langerhans cells. So this is how it happens, and dysregulation of incretin system happens in type 2 diabetes mellitus. We know it. The EPI, that is exocrine pancreatic insufficiency in pancreatitis, is well known to damage even the beta cell. So it's a interplay between the endocrine and exocrine pancreatic tissue is what we need to understand. Next slide. There are quite a few references. There are n number of things which you keep on reading. Otherwise, if you go to Google or Wikipedia, deal with exocrine pancreatic insufficiency, and you will find thousands of references from 2010 to 2022. So how do we diagnose? We'll go to the next slide fast. Somebody is calling me here. Anyway, so this is the timing of diabetes workup in relation to the first attack of pancreatitis. If somebody develops pancreatitis, when do I do the sugars? Actually, let me tell you how do we diagnose type 2 diabetes mellitus? We know it, that HbA1c of more than 6.5 and the fasting sugar which is high. So before the pancreatitis attack, or even within 90 days of pancreatitis attack, or after the 90 days of pancreatic attack, we can still diagnose the type 2 diabetes mellitus with HbA1c of more than 6.5 with fasting blood sugar more than 126. The PPDM stands for post-pancreatitis diabetes mellitus. Similarly, the criteria is almost same all throughout, meaning here HbA1c is not available within 90 days, but I would personally say that these are not very important things. Diabetes to diagnose after chronic pancreatitis, after 90 days we can confirm it, but the hyperglycemia happening even during the attack, immediately post-pancreatic attack, or new onset of diabetes after pancreatitis, that is called no DAP. I don't know whether I need to go into the or remember those nomenclatures, but I only want to tell you each pancreatic attack you have to care and check whether type 2 diabetes mellitus diagnostic criteria are met or not, and we need to repeatedly check the sugar as well as HbA1c of that particular person. Next slide. Next slide, please. Yeah, classification. Now there are too many things. Frankly speaking, I am also finding it difficult to remember. But post-pancreatic pancreatitis diabetes mellitus (PPDM), whether it is acute pancreatitis or chronic pancreatitis. So PPDM A, PPDM C. C stands for chronicity. Pancreatic cancer-related diabetes (PCRD). Cystic fibrosis-related diabetes (CFRD). So these are few things. I would, as a healthcare professional, would remember that any pancreatic disease, whether it is pancreatitis, whether it is cancer pancreatic, whether it is pancreatectomy, meaning hemipancreatectomy or total pancreatectomy, whether it is due to cystic fibrosis or what, I need to keep in mind that endocrine pancreatic dysfunction does happen, and I need to check and diagnose that person with it. Now, this is a special entity, antecedent diabetes mellitus in pancreatitis, ADMP. There are too many short forms. I'm not encouraging you all to remember it, but just remember that pancreatic disease, exocrine pancreatic disease, and diabetes are very interrelated. Anything can come before. You might have an attack of pancreatitis, but you have to remember that hyperglycemia needs to be checked. I need to see whether this person is developing diabetes or not. Or in all diabetic, I need to check whether the person has exocrine pancreatic insufficiency or not. This, if every healthcare professional remembers, my purpose of this particular lecture is completely served, and I thank Mr. Kulkarni for that. Next slide. We'll go to the next slides. Few of them are there. So what are the factors where I can diagnose exocrine pancreatic insufficiency in diabetes? First is, once the diabetes is of long duration, if at all you see a histopathological structure in pancreas, I hardly see in any diabetes patient the histopathology or pancreatic biopsy of that particular person. But if the person is poor at his own diabetes control, I need to think whether he is suffering from EPI, that is exocrine pancreatic insufficiency. Symptoms, very important symptoms like abdominal discomfort, pain, weight loss, diarrhea, bloating, and gas. When the person is not on metformin, not on acarbose, not on moglibose, I need to check the person's symptoms are related to exocrine pancreatic insufficiency or not. That I need to check. Person with microvascular and macrocell compilation with diabetes, I need to check. Laboratory findings like serum amylase, serum lipase, and so many things. Sonography showing atrophic pancreas in a diabetes person, I must think whether the person is suffering from exocrine pancreatic insufficiency or not. So similarly, pancreatic volume, which we can see on sonography as such. Next slide. Next slide, please. Yeah. Here now what we want to see, those patients who need insulin, in which patients I need to suspect, in patients where I need to see that the pancreatic insufficiency needs to be treated or supplementation need to be given. These are those patients, those who are on insulin, those who are uncontrolled diabetes, those who are early onset diabetes. I would say all diabetics, I shall keep in mind exocrine pancreatic insufficiency is there or not. Bas. Next slide. So how do I manage this? If at all I need to give him some metformin, some sulfonylurea, some DPP-4 inhibitor, some ultimately insulin or dapagliflozin. In addition to that, I need to keep in mind whether I need to give him something like pancreatic enzymes. Do I need to treat exocrine pancreatic insufficiency? So how do I manage that? Next slide. So here, I think the importance of management of EPI in diabetes is what been indicated. When we compare those patients with type 2 diabetes mellitus, the DEP are associated with higher risk of insulin requiring diabetes. Hypoglycemia is higher in those with DEP, that is diabetes of exocrine pancreatic insufficiency. Diabetic neuropathy, all complications of diabetes are more commonly seen in those patients who already have exocrine pancreatic insufficiency and diabetes coming out of it. So such kind of thing. In addition to that, their all-cause mortality is also higher than those patients who are just type 2 diabetes mellitus but no exocrine pancreatic insufficiency. Next slide. Next slide, please. Yeah. Here I want to say, how do I treat the EPI? Because we need to make them absorb their digestion material better. I need to check whether the person has steatorrhea, that is fat content of the stools. I need to check whether the insulin requirement of the person is better improved, because when I give enzymes, I improve the exocrine pancreatic insufficiency, the malabsorption improves, the insulin sensitivity improves, and the person feels better altogether. So insulin requirement actually reduces if you add pancreatic enzymes to the treatment algorithm to these patients, as well as their nutritional status improves, because this pancreatic enzyme help digest their proteins and fat better, and therefore they are given with the meals, whether it is lunch or dinner or 3 times a meal, with 3 times a day, if the as per the patient requirement is there. Next slide. So what are the goals? We need to control the hyperglycemia. HbA1c goal, we know that. We need to also correct the exocrine deficiencies. We need to see to it that the person achieves a better nutritional status. We see a lot of patients with very lean and thin pancreatic, lean and thin type 2 diabetes mellitus. So those patients are actually nutritionally poor, and therefore the EPI, the exocrine pancreatic insufficiency, needs to be suspected in those patients much more, especially when they give history of diarrhea happening quite often without metformin or without any other cause which we can find. Those patients with abdominal symptoms, bloating, gases, regurg, all those things. Next slide. Next slide, please. Yeah, we'll go a little faster. So now how do we do the treatment of such patients? Obviously, diabetologist has to treat the diabetes, but also we need to have a specialist diabetes nurse. We hardly have in India, maybe about 10% of our diabetic patient might be getting those care from diabetic nurse, but our diabetes educator or diabetes dietitian in the clinic, one should help them, not in addition to the diabetic diet. In addition to that, they have to give the clear attention towards the enzymatic insufficiency. So what food they need to avoid, like as I said, the fat content in the meal, the protein content in the meal, and do they require any supplementation of pancreatic enzymes from outside, is what actually the discussion should be happening between the dietitian and the diabetologist, or the healthcare professional and the dietitian. So we give ultimately OHA, the oral antidiabetic therapy. In addition to that, we give exocrine insufficiency. And you can see here, such kind of manifestation happen only when more than 90% of pancreatic affection has happened. The pancreatic enzymatic replacement therapy required is a very late stage. Pancreas has a good reserve. What I mean by that is this: the pancreatin helps actually improving the response to insulin also. Meaning what? One person is on 10 units of insulin dose, the insulin dose will be reduced if we add the pancreatic enzyme to that person's treatment regimen. I might require only 6 units to be given to that patient because the response to the insulin will improve. Similarly, exercise schedule also needs to change. The frequent eating hypoglycemia needs to be avoided. So we need to talk to the person regarding exercise, adequate nutritional supplementation before exercise and after exercise. We need to talk about no alcohol and no smoking to those patients and maintaining their healthy weight. Quite often, the person with exocrine pancreatic insufficiency are lean thin. They are with low BMI with type 2 diabetes mellitus rather than those obese, our usual diabesity or metabosity or obesity related diabetes. So those patients with exocrine pancreatic insufficiency are usually lean thin if their pancreatic affection has happened beyond 90% of pancreatic damage. So remember this, lean and thin type 2 diabetes mellitus, think of pancreatic insufficiency. Next slide. Next slide, please. Yeah. So we need to counsel them about pancreatic enzyme replacement therapy. If at all required, we need to give them. Special attention needs to be given to the glycemic control. Structured exercise training is required so that their nutrition, the protein and the fat they take should be utilized for their body, and the muscle mass is what we need to think of. The dietetic support is little different than plain type 2 diabetes mellitus because we need to give an attention to their fat content of the meal, the protein content of the meal, especially whether they are gluten sensitive or all those things we need to check for. And they require more frequent monitoring of sugar to avoid hypoglycemia. Uh, Sometimes we need to ask repeatedly for loose motions or bloating or gases, or their intestinal motility symptoms can be inquired little more commonly than type 2 diabetes mellitus patient. Next slide. So we have now come to the pancreatic enzymatic replacement therapy. So this is what is the algorithm. Check for the especially the symptoms for pancreatic insufficiency, that is bloating and gases and abdominal discomfort. If at all those symptoms are happening in the box 1, given they are in box 2, what investigations we need to do, whether we need to check the stool examination, what is the frequency, what is the type of stool, whether it is sticky stool, that indicates the fat content of the stool, whether what blood investigations we need to do, because they usually have a deficient fat soluble vitamins. So we need to check for their calcium level, we need to check for their vitamin D level, all those things are required. And later on, what do we give them? We give them PERT. PERT is pancreatic enzyme replacement therapy. It needs to be given with or after food immediately, and we need to titrate the dose upward if required for the given patient, the dose of Enzelo tablet. General measure, obviously we need to supplement them with vitamin D and other fat soluble vitamin, like even vitamin A for that matter. Supradine is another tablet which might require into the treatment protocol. We need to ask them to stop smoking, alcohol, their fat content in the meal need to be examined. Dietitian needs to look into it, and the regular sugar monitoring is required. Whether those patients can continue sulfonylurea or insulin, does the insulin requirement reduces, whether the person gets into hypoglycemia. To avoid that, we need to reduce the insulin dose of the person once we start on PERT, that is pancreatic enzymatic replacement therapy. Next slide. Next slide, please. Yeah. So let's review the treatment again after every 4 to 6 weeks. If required, we need to increase the dose of pancreatic enzyme replacement, right from whether from 10,000 units to 25,000 is required or what, all that we need to see. If the hyperacidity symptoms are there, the regurg syndromes are there, if the esophagitis is happening, we can add proton pump inhibitor to that. For that, we might have to require the help from the gastroenterologist. If at all, having done all that, if their symptoms do not improve or their response is not to the optimum, we need to take help of our gastroenterologist friend. And don't think any kind of insufficiency, why I am going to refer this patient to gastroenterologist and all that. Nothing like that. What we call it as auge dharu supantha. So we need to improve the patient's condition. If we require help from gastroenterologist, whether endoscopy is required, whether sonography is required, whether stool examination is required. All that thing we need to check for, and do not hesitate to help the patient to improve his own condition. The diabetes control also better with the help of gastroenterologist, and it is always better to take help from a friend rather than losing on patient's good health. Next slide. Next slide, please. Yeah. So supplementation, go on. Next slide. How do we supplement those things? Consider we actually, when we supply those things now, there is a great clinical improvement happening to the patient, because his bloating symptoms go away, his abdominal symptoms go away, his gases will go away, his loose motions will go away. So he will feel better, he will eat better, he will take fair amount of protein and fat material also, he will digest all that, his exercise tolerance will improve. In addition to that, his postprandial sugar also will reduce, because the insulin sensitivity will improve. What you need to give the insulin, say X, you need to give probably -2 units or -4 units. The insulin requirement per each dose. I mean, if you are on basal bolus regimen, the requirement of the insulin with the meal will reduce. Similarly, the HbA1c control will be better. Your glycemic targets will be achieved better, and obviously the symptoms are better. So person feels better. The sense of well-being of the patient is what is our sense of well-being. पैसा तो कोई भी कमाता है, but we need to see the happiness onto the patient's face. Next slide. Yeah. So this is how we give them the pancreatic lipase supplementation. If the symptoms do not improve, I mean, symptoms do not manifest till the duodenal lipase level falls below 5 to 10% of normal postprandial level. Frankly speaking, let me inform you, duodenal lipase, postprandial state, I need to do 2-3 times the test and all that. ठीक है, all these things are good as a theoretical level, therapeutic level, or as a theory level, or whatever is given in the documentation. But our clinical acumen would not fail if you diagnose a patient with pancreatic insufficiency, exocrine pancreatic insufficiency, supplement. You can even do a trial supplementation, and if the patient feels better, you have a therapeutic response that the patient has felt better. That means patient has a lipase insufficiency. That's also good. So suspicion is important. PERT therapy is primarily recommended in all for API. The lowest dose is 25 to 40,000 of international units of lipase, and you can go up to 75 to 80. PERT is most effective when it is given with the meal, and therefore the supplementation of fat soluble vitamin is also required, like vitamin D, vitamin E, vitamin A. All these things are required. Next slide, please. I'm going a bit faster because my all healthcare professionals are very competent. They just need some stimulus that think of exocrine pancreatic insufficiency, and they will supplement the patient with the pancreatic enzymatic replacement therapy. So what are the benefits we see? The symptoms will improve, the fat and protein absorption will improve, the steatorrhea, that is the sticky stool, will go away. It will go down to less than 15 gram per fat per day. The glycemic control will improve, the postprandial sugar will improve, the incretin hormone will improve. So when we want to give DPP-4 inhibitor, we might require only 50 milligram of your vildagliptin or sexagliptin, or say for that matter sitagliptin, instead of 100 milligram of your DPP-4 inhibitor. So even there patient's benefit happens. And most important, quality of life improves. Next slide. Next slide, please. Yeah. So the insulin sensitivity improves. As I told you, the requirement of insulin dose goes down once we start the pancreatic enzyme replacement therapy. Next slide. Yeah. So this is what actually I have told you just in one sentence. Here there are lot many parameters are given: the low pancreatic enzyme, the high pancreatic enzyme, and all those things. So insulin area, if we check their fasting insulin level, nowadays there is a fad now checking serum insulin, checking serum C-peptide level. So all those things are on the improving side when we add the pancreatic enzyme supplementation to them. And ultimately, the blood glucose and the A1C also improves. So good glycemic goals are achieved. And so yeah, you go ahead with the next slide, no problem. Go ahead with the next slide. Yeah. So the supplementation of pancreatic enzyme improves the fat and protein absorption in those patients. Here you can see in the graphical way, the red bars are enzyme supplemented and the blue bars are placebo, that is no enzyme supplemented. Here on the first graph, you can see the fat absorption improves to the tune of almost 36% as compared to 7.5% of placebo. And here the that is nitrogen absorption, that means protein absorption, almost 33.4% of absorption improves as compared to 3.7 of placebo, that means where the enzyme is not given. So graphically it is being shown through this paper which was published in 2016, and you can see the fat and protein absorption improves, and once that absorption improves, their muscle mass will improve, their sense of well-being will improve, their exercise tolerance will improve. All these things happen with supplementation of pancreatic enzyme. Next slide please. Yeah, so I think there are too many clumsy slides, but let me tell you, the incretin, the glucagon like peptide activity also improves with supplementation of pancreatic enzyme. That's the crux of your this particular slide. What does that do? The GLP-1 actually improves the gastric emptying. It does not make you stagnated stomach. The GLP-1 secretion improves with the enzymes, as well as the glucagon also comes down to normal, meaning normally otherwise hyperglycemia is due to high glucagon level, but then that also comes down, and the hypoglycemia does not happen to that patient. That is what actually the pancreatic enzyme supplementation will do. Next slide. So these are few case studies, case 1, case 2, case 3, case 4. They are of different age group. That's why these 4 cases are put here: 46 year, 57 year, 24 year, 36 year. So don't feel that this pancreatic insufficiency happens only at the higher age, or 50 or 60 or 70 years of age. It is quite often seen even at the age of 24 or even 36. And those patients with pancreatitis or cystic fibrosis related diabetes mellitus, the HbA1c is to the tune of 8.6 to 10 to 11. And once we supplement with the pancreatic enzymic replacement, their HbA1c improves to the almost normal level, 6.7 to 7.6 to 6.4 to 7.1. In addition to that, pancreatic enzyme replacement does additional few things. That is, the high triglyceride level also reduces, and the total cholesterol and high triglyceride level, which happens with pancreatitis or which happens with cystic fibrosis related diabetes, also reduces. MEN is multiple endocrine neoplastic syndrome type 1. In that also you get good achievement of glycemic target, that is HbA1c of 7.1, with normalization of high triglyceride and normalization of high total cholesterol. Next slide. Yeah, so these enzymes are safe. The safety measures have been taken care of. The adequate studies have been done against placebo. This is paper from 2016, and you can see here the protein absorption. When the pancreatin is added, 33.4% improvement in protein absorption happens. So do not allow your patients to lose protein, lose fat from the stools because of lack of pancreatic enzyme. Do supplement them adequate enzyme in addition to your oral hypoglycemic agents in type 2 diabetes mellitus patient. So keep exocrine pancreatic insufficiency in mind while treating type 2 diabetes mellitus patient. Next slide. So the conclusion, last slide, next slide. So exocrine pancreatic insufficiency is quite common, whether it is type 1 diabetes mellitus or type 2 diabetes mellitus. Remember this. And that can impact your treatment outcome of simple diabetes also. You might require more number of units of insulin to achieve the glycemic goals. You might require more tablets Sometimes we go from 3 oral agent to 4 oral agent, which is not logical. Think of exocrine pancreatic insufficiency, supplement them with pancreatic enzyme, and you will see the diabetes also comes under control. So those surprises are better always with the patient. These are happy surprises for you as well as your patients. So these are the benefits of your exocrine pancreatic insufficiency being treated with the enzyme supplementation. It improves the response to treatment of diabetes. The insulin response improves, so insulin requirement reduces, as well as your incretin response improves. So DPP4 enzyme inhibitor, DPP4 inhibitors which we are using otherwise, the gliptins, that doses also might reduce. And let me also inform you that these enzyme supplementations are completely safe as placebo. Thank you very much for your patient listening. If there are any questions from anywhere, I am more than happy to answer as well as learn from all you. Thank you very much.
Thank you, so I'm immensely thankful to Dr. Sanjay Gandhi and for the efforts that you have made for making this topic very interesting and giving the explanation for all, each and everything. And that was very beautiful explanation, sir. Thanks a lot, and I will request all the viewers to give your queries if you are having some. Then you can post it in the text box.
Thank you very much. I appreciated your patient listening in spite of the fact that I have crossed 20 minutes more than your scheduled lecture.
No, sir, but it was quite an explanation for everything, and that's why I think viewers are getting benefited because of that, sir.
Thank you.
Thank you.
Thank you.
So I'm asking viewers to post your queries here in the comment box, so Dr. Gandhi can answer those. One query already we have received, sir. That is from Rajendra Kumar. So he's asking, is pancreatic cancer commonly seen with people with type 2 diabetes? So should we investigate more frequently for cancer pancreas?
Frankly speaking, we quite often do sonography of these type 2 diabetes mellitus patient, and we see the commonest finding as fatty liver. The pancreatic cancers do happen with type 2 diabetes mellitus patient. As such, all cancer incidences are higher with type 2 diabetes mellitus patient, whether it is uterine cancer, whether it is lung cancer, whether it is pancreatic cancer for that matter. But there are no specific guidelines that apart from doing annual sonography for these patients, there are no any other guidelines unless patient is losing weight in spite of being on insulin, unless patient is having anorexia and all those kind of thing. Sometimes patients might get melena, and if at all some lymph nodes are seen on sonography, then only we get that click of pancreatic malignancy. It is quite often that we diagnose pancreatic cancers pretty late. There are quite a few lucky ones who are captured early, and Whipple's procedure can be done faster earlier. My friend Dr. Shailesh Puntambekar actually keeps on telling us always that quite a few Whipple's patients are completely, kind of risk free, or 5-year survival is far better if we catch them early. So that's how. But frankly speaking, there are no particular regimen that annually or 6 monthly you have to do tumor marker or something like that. Nothing like that. But your high index of clinical suspicion will point towards a malignancy. You would be surprised to note, to answer this question, I am more happy because uh, just a month back, just before Diwali festival, young man of 40 who is now undergoing chemotherapy in one of the hospital in Pune was diagnosed with hepatic cholangiocarcinoma. Only one important thing, risk factor was there with him, was obesity. His BMI was above 40. So obesity is associated with many cancers. Obesity is associated with diabetes mellitus itself. So high index of suspicion in obese type 2 diabetes mellitus patient should be kept, whether it is pancreatic cancer, whether it is gastric cancer, whether it is lung cancer, whether it is uterine cancer in the females. So yes, like in female patients, we have that human papilloma virus test and all those kind of thing. But for pancreatic cancer, there is no protocol, but we do sonography of all patients at least once in annum per year. We ask them to do an annual checkup, which includes 2D echo, ECG, all blood parameters, including your urine routine complete, the UACR, all those things. So annual checkup is required for those diabetic patients. In that, there is a luck that you might capture something like this, and we might send the patient for the surgical workup or pancreatic cancer workup. I think there is additional one question I saw just now. What was that?
Yes, it is like diabetes mellitus occurs due to high insulin production. So I think that question has got uh, half written.
Doesn't matter. Diabetes does not happen because of high insulin production. Diabetes is actually an indicator that your insulin production is insufficient, or the working of insulin all over the body, that is in your skeletal muscles, in your adipose tissue, what we call it as peripheral insulin resistance, the insulin resistance in liver. So insulin action does not happen adequately or effectively, and because of that, the glucose level in the blood rises, and that is what we call as diabetes. So high insulin actually gives rise to hypoglycemia, low sugar, rather than diabetes mellitus.
So now I would like to ask Mr. Ullas Kulkarni to extend the vote of thanks for Dr. Sanjay Gandhi. So over to you, Mr. Ullas Kulkarni.
Kulkarni sir, are you there?
Very much there, sir. So I express my sincere thanks to
Oh,
Gandhi sir for helping me as well as Juventus as a whole in this endeavor of knowledge spreading and making this little overlooked topic more consciously and with a very simple aspects. So all the important aspects which were little complex, you really made it simple to understand for every audience, and I am sure this will be of great utility for all the audience. So once again, thank you very much, Gandhi sir, and I express my thanks to our head office teammates, that is Harshada and Prachi as well. So thank you very much once again, and thanks all audience for your patience listening. Thank you.
so Angelo is Harshada.
Yes, sir. Yes.
Yeah,
Yeah, thank you all team
Thank
members, and thank you Mr. Kulkarni for giving me this opportunity to learn more about exocrine pancreatic insufficiency. Thank you.
thank you, sir.
Thank you
Thank
so
you,
much.
everybody.
Thank you. Bye.